Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be discussing hyponatremia, which is one of the more difficult concepts, I think, to learn for step one, but it's incredibly important because you're likely to see a lot of questions on it on step one. Additionally, it's highly likely that you will run into patients with hyponatremia in clinical practice. Hyponatremia, as you know, can be incredibly dangerous because if we don't have the appropriate amount of salt in our blood, this can disrupt the electrochemical gradient, specifically in our cardiac cells, leading to arrhythmia and possibly death. So important both for clinical practice as well as for step one knowledge. Now, before we dive into all the different causes of hyponatremia, what is hyponatremia? Well, a general rule of thumb is that our sodium should be between 135 to 145, but if we have a sodium less than 135, that is what we term hyponatremia because we have too little sodium in our blood, and that is where the hypo in hyponatremia comes from. Now, once we've determined that our patient has a hyponatremia, we need to further evaluate them because depending on the cause of their hyponatremia, the treatment could be vastly different. So if we don't know what type of hyponatremia they have and we try to treat them, we could actually make it worse. So it's important to differentiate what is causing the hyponatremia. How we do that is first by ordering a serum osmolality. Now, normal serum osmolality is 280 to 295. If you're within this normal range, we say that you are isotonic, iso meaning the same, isotonic to the normal range. If you are below this range, we say that you are hypotonic, so you have a hypotonic hyponatremia. And if you are above this range, you are hypertonic. Osmolality, as we've talked about in different videos, is basically a measurement of how concentrated something is. So if we have a higher osmolality, more concentrated, that's why we say you are hypertonic. And why it's important to first order the osmolality is because just by ordering the osmolality right off the bat, it can help us break down your hyponatremia into three relevant categories. We'll talk about hypotonic hyponatremia a little bit later because it's the most complicated, but if it comes back that your patient has an isotonic hyponatremia, for example, that's a great clue to what is causing their hyponatremia because there's only a few things really that cause this. And the two that you should be most aware of for step one are hyperproteinemia, so too much protein in the blood, or hyperlipidemia, too many lipids in the blood or fats in the blood. These are usually chylomicrons or triglycerides. And both of these are going to lead to a reading of hyponatremia, so sodium less than 135, because if you have too much protein or too many lipids in your blood, it's going to mess with the machines that we use to auto-analyze the amount of sodium in the blood and cause them to read out something that may not be entirely accurate, but will read as low sodium. And because this is kind of fake news, you may not actually have low sodium, but the machine is just confused because of all the protein and the lipids. You may sometimes hear this category of hyponatremia referred to as pseudo-hyponatremia, and it's pseudo, right, because it's kind of a fake hyponatremia. It's really just that you have too much protein or too many lipids in your blood, causing this machine to read out incorrectly that you have low sodium. So if we have a normal osmolality but low sodium, that's a pretty great diagnostic indicator that you're in this category right here. Similarly, if you have hypertonic hyponatremia, that's another great clue that can narrow down to a set of diagnoses with similar pathology. So all of the ones in this bucket pretty much work the same way in that we are adding something, a solute, to your blood, whether that is glucose, in the case of hyperglycemia, mannitol, sorbitol, glycerol, or maltose, so any random sugar basically, or radiocontrast dye. So we're adding something to your blood. Because we've added a solute to your blood is now hypertonic. Because your blood is hypertonic, then through the process of osmosis, water is going to flow out of your cell membrane, water is exiting the cells, there's increased water in your blood, so as the water exits your cells, it is going to dilute your blood. And when we have this dilute blood, that causes hyponatremia, along with lower readings of most of your other electrolytes. One final note here, IVIG may also contain mannitol in certain formulations, and that's a great tricky association to be aware of for step one. Okay, so if you order a serum osmolality and you get an isotonic or a hypertonic reading, that's great. It's really useful. You're very close to being done with your diagnosis. However, if you get an osmolality and the reading comes back as hypotonic, it gets a little bit more complicated, as you can see from all of these different branches coming off of your diagram. So if we order a serum osmolality and it comes back hypotonic, we're going to have to use a couple extra steps to determine what is causing this hyponatremia. So first, we're going to obtain a volume status. And a volume status is not actually a lab value. This is going to be from a clinical diagnosis. I personally think this is one of the most difficult things to determine clinically. But on step one, lucky for you, they're usually just going to tell you what the volume status is. If they have a high JVP and edema, that's going to make them hypervolemic. If they're super tachycardic and their mucous membranes are dry and maybe they have low blood pressure, that means they're hypovolemic. So those are the clues that are going to help you with your volume status. The next lab values that we're going to want to order is we're going to want a urine sodium and we're going to want a urine osmolality. Now, both of these lab values are basically quasi-measurements of what is happening with your RAAS and ADH systems. So RAAS, your Renin-Angiotensin-Aldosterone System, we're going to measure whether that is on or off by measuring the urine sodium. If your urine sodium is above 30, we are going to say that your RAAS is off. If your urine sodium is low, if it's below 30, then we're going to say that your RAAS is on. So we're using this urine sodium value as a proxy for whether RAAS is on or off. Similarly, we're using our urine osmolality as a proxy for whether ADH, antidiuretic hormone, is present in circulation. So if our urine osmolality is high, that means that we are going to have ADH present because we're resorbing all that water. There's less water in it to dilute the urine, so it is very concentrated. So urine osmolality greater than 100 means that our ADH is present. Less than 100 will say that ADH is relatively absent. RAAS is going to be associated with the urine sodium, true, but it's also going to be very important for determining our volume status, our intravascular volume status, I should say. So RAAS is going to be more responsible for your intravascular volume status than our ADH is, and ADH is going to be more responsible for your urine osmolality and is not as responsible for volume status. And you should be thinking about that as we go through the physiology of each of these diagnoses. Okay, so we've ordered our serum osmolality that came back as hypotonic. So we know that we have a hypotonic hyponatremia. Now let's talk about our different types of hypotonic hyponatremia. First, we'll talk about our hypovolemic hyponatremia. So again, this patient might have an increased heart rate. They might look like they have dry mucous membranes. They're looking kind of dehydrated and their heart is working harder to keep their blood pressure up in the setting of having lower volume. So they are hypovolemic. Okay, and there's two sets of diagnoses basically within a hypovolemic hyponatremia that are both going to be distinguished by the urine sodium. And urine sodium, as I just told you, is going to be kind of a proxy for RAAS. So the difference here is whether RAAS is on or RAAS is off. So over here in your RAAS is active column, we have things like dehydration, vomiting, diarrhea. So basically what's happening here is you're getting dehydrated because you are losing fluids, right? You're losing fluids and salt. And the natural response to that, the appropriate response to that, is for your body to turn on the RAAS system and do everything it can to preserve your pressure by saving more volume intravascularly, as well as, vasoconstriction and all the other things that RAAS does. So RAAS is going to be appropriately on in this set of diagnoses. By contrast, over here in these set of diagnoses, these are all going to be things that are disrupting RAAS's normal function. So if you are taking a bunch of diuretics, like loop diuretics, like furosemide, for example, that's going to be disrupting all the good work that aldosterone is trying to do. If you're taking an ACE inhibitor, for example, again, you're going to have less aldosterone, so it's disrupting the RAAS system. A nephropathy, or sometimes it's called a salt wasting nephropathy, is similarly going to be a problem, usually in your kidney tubules, that is going to lead to your kidney's inability to really do its job and hang on to that salt, so you're peeing out more salt, so RAAS is again getting disrupted. If you have a mineralocorticoid deficiency, aldosterone's a mineralocorticoid, so you are not having aldosterone around to do the job of the RAAS system. And then finally, cerebral salt wasting syndrome. This one, the pathology isn't entirely understood, but it's basically an insult to your brain, most commonly from an aneurysmal subarachnoid hemorrhage that leads to your brain's inability to regulate your fluid balance. So this is likely a problem with the RAAS system as well. So over here, because the RAAS system is not functioning appropriately or is getting disrupted, it should make a lot of sense to you that we categorize them by your urine sodium being greater than 20 or 30 and our RAAS being essentially off, because the RAAS getting disrupted is the problem in this pathology. By contrast, over here, your RAAS is acting appropriately. You're just losing fluid and salt through another means, vomiting, diarrhea, or dehydration. And if you look over here on this chart, that's pretty much how it all shakes out, right? So when it comes to hypovolemic hyponatremia, the most important thing to do to distinguish between what category of diagnosis we are looking at is to determine what's happening with the RAAS, and then, of course, go back into the patient's natural history. Were they on a diuretic? Were they taking an ACE inhibitor? Do they have nephropathy? All those things that will lead you to the correct diagnosis. Moving on to euvolemic hyponatremia, hyponatremia. I think this one is a little bit more tricky. Usually what's happening in this set of pathologies is that we have this RAAS and ADH system kind of balancing each other out. So usually one is off and one is on, not always, but that's usually what's happening, and that's why we have a euvolemic state, because there's a little bit of balance here. So the first thing that can cause a euvolemic hyponatremia is going to be SIADH, syndrome of inappropriate antidiuretic hormone. And of course, because it's the syndrome of inappropriate antidiuretic hormone release, antidiuretic hormone levels are going to be high, our urine osmolality is going to be high, but our RAAS system is going to be off. And that should make sense to you, because if your body is trying to hang on to all this excess water, that's going to increase your blood pressure. And as that stretch occurs within your vessels, within your heart, an atrial natriuretic peptide gets released, the RAAS system is going to be shut off. So the RAAS system is shut off here, but ADH is high. And that's why in SIADH, we have a euvolemic hyponatremia, because our RAAS system is off. It is counterbalancing the effects of resorbing all of this water. Now, the second two pathologies that can cause a euvolemic hyponatremia have a pretty similar mechanism: psychogenic polydipsia, which is just drinking way too much water because of excessive thirst, and beer potomania, which is taking in too little solute. What's happening with both of those is that your blood becomes pretty dilute, either because you drank a bunch of water and diluted it, or didn't have enough solutes in there, so it's pretty dilute from either one of those factors. And then because your blood is dilute, it is not delivering enough sodium to your macula densa cells, and that is going to lead to RAAS turning on. So RAAS will be on in both of these sets of diagnoses, but your ADH system, interestingly enough, will actually be off. So for both psychogenic polydipsia or beer potomania, you're going to have ADH off, but RAAS is going to be on. And then finally, with ACTH deficiency, the key thing to remember here is that your RAAS system is going to be off, but your ADH is going to be present, and that should make sense to you, because when you have low ACTH, it's deficient, you are going to have more CRH, because there's not that negative feedback occurring, right? So CRH levels are going to be elevated. When CRH is elevated, vasopressin is often elevated or increased. So in adrenal insufficiency, you're going to have increased antidiuretic hormone present, but your RAAS is going to be off. And then with endurance exercise, it's a little bit more variable. This is like people that are running marathons, etc. And it kind of depends. If this person's been running a marathon and only drinking water, which has no solutes in it, or if they've been running the marathon and doing their endurance exercise and repleting with really sugary, salty drinks. So I'm not giving you a hard and fast rule for endurance exercise, but for the rest of these, it's pretty reliable what the RAAS and ADH systems are doing. And that is why your urine sodium and urine osmolality are going to be excellent tools for you to be able to use to distinguish which one of these euvolemic hyponatremias is occurring, in addition to elements in the history and physical exam. And then the last set of diagnoses I want to talk about is if you have a hypotonic hyponatremia, but your patient is hypervolemic on physical exam. So maybe they have an elevated JVP, maybe they have a bunch of pitting edema, they're going to be hypervolemic globally. However, in most of these diagnoses, a key differentiation I want to make is that while they may be globally hypervolemic, they're oftentimes going to be intravascularly hypovolemic. And what I mean by that is that even though you have all this excess fluid in your body globally, generally, it is not making its way to the kidneys in a way that the kidneys perceive that you have enough volume, enough blood pressure, and that is why they're going to turn the RAAS on. So for example, in heart failure, the problem is that your heart is not pumping well enough to perfuse your body, right? Thus, we're pumping really slow, and then all of the extra fluid in your blood leaks out into your third space. That's why we say third spacing when you have this edema in your legs and all of this extra fluid on your body. However, that fluid is not getting pumped to the kidneys effectively, so your kidneys are not seeing a high blood pressure. Thus, even though while your body is hypervolemic, your kidneys think that you are hypovolemic because they're not seeing the blood pressures that they would see normally when they are getting perfused well. Thus, your RAAS system is on. Similarly, in liver failure, the problem is that one of the things your liver does is makes albumin. When we don't have enough albumin, we are unable to hold our volume within our vascular system. When we're not holding our volume in our vascular system, then we are going to have low volume intravascularly, intravascular hypovolemia. Your kidneys are going to sense this and again turn the RAAS system on. In nephrotic syndrome, it's basically the same problem. You have low albumin. One of the things that nephrotic syndrome does is it spills a bunch of protein in your urine. That protein oftentimes is albumin. And when we have low albumin, like we just talked about, we're not holding our fluid in our vascular system. Our kidneys see less fluid. They turn the RAAS system on. Kidney failure is a little bit different, but the main takeaway for this set of diagnoses is that our RAAS system is going to be on for all of them, and ADH is usually going to be present as well. So there's a lot of information about how to differentiate between different causes of hyponatremia. The key things I want you to take away from this are the first thing we do is we order an osmolality because we want to know what bucket we're in. If it's isotonic, great, we have a pseudohyponatremia most likely. If it's hypertonic, that's probably something that we put into the blood. So something like a sugar, maybe a radiocontrast agents, maybe they got some IVIG, that's what's causing it. If it comes back hypotonic, that's when it gets a little interesting. That's where the money is, because that's what they're going to ask you about most likely. Then you need to determine what is going on with our RAAS and our ADH and which bucket are we in. If they're hypovolemic, you should be asking yourself, okay, is the RAAS on or off? Because if the RAAS is on, it's usually dehydration, vomiting, diarrhea. If the RAAS is off, then it's usually something disrupting the RAAS system inappropriately, one of these suspects here. Euvolemic hyponatremia, you should again be looking at what's going on with RAAS and ADH. If ADH is elevated but RAAS is low, it might be SIADH or ACTH deficiency. You can kind of differentiate between those given the history. If the ADH is low but the RAAS is high, then we might be thinking psychogenic polydipsia or beer potomania, depending on what the history tells us. And then if we have hypervolemic hyponatremia, that's going to be one of these diagnoses that is causing us to be intravascularly hypovolemic, and we can differentiate between history and other symptoms as well. So that's how we diagnose our different types of hyponatremia. But how are we going to treat the hyponatremia? Well, usually we treat the underlying cause if there's one that is present. So if someone has liver failure that is causing their hypervolemic hyponatremia, we should treat their liver failure and it'll probably improve. If someone has dehydration, vomiting, or diarrhea, we would give them something like normal saline because that is what they're losing. They're losing salt and water. If someone has SIADH, however, should we give them normal saline? If you said no, you would be correct, because if we give them normal saline, their antidiuretic hormone is just going to hang on to all that water. And since their RAAS system is off, we're not going to hang on to any of the sodium. So effectively, you've just given them a bunch more liquid to dilute their blood, and you're going to make their hyponatremia incredibly worse if you give someone with SIADH normal saline. So I think that's a great example of why it's important also to diagnose what is causing the hyponatremia, because the treatment of these two different causes of hyponatremia directly opposite, right? Give someone with dehydration, vomiting, or diarrhea some normal saline. That is the correct treatment. If we give that to someone with SIADH, we could actually worsen their hyponatremia. So incredibly important to understand what is causing hyponatremia, because the treatments can be the direct opposite. And in SIADH, you might actually fluid restrict that patient versus giving them more normal saline. If we do determine that we are going to fix their hyponatremia with normal or hypertonic saline, it is incredibly important that we start at a low dose and we go slow. And that is because we want to avoid at all costs the devastating outcome of osmotic demyelination syndrome. Osmotic demyelination syndrome occurs when we have had someone usually who's been hyponatremic for a very, very long time. So usually you have sodium that is floating around in your serum, and that sodium is trying to steal water through osmosis and pull water out of your cells, especially your brain cells. And your brain cells, because they want to remain turgid, have a couple of different ways of dealing with this constant pull from the sodium. But if your sodium has been low for a very, very long time, your brain cells get a little lazy and they say, there's no sodium around, we don't need to hang on to our water that much. Why would we be producing all this extra stuff to hang on to our water? We'll slow down. And when they do that, when they adapt to that hyponatremia, that's fine in the moment. But if we then replete their sodium too quickly and we give them a bunch of salt, your brain cells are not ready to hang on to all that water. So the salt pulls a bunch of water out of the brain cells immediately. And that osmosis is what is going to lead to demyelination. And that demyelination of those brain cells can have devastating effects, including loss of motor function, dysphagia, so inability to swallow, and catatonia. And it leads to something that is often referred to as the locked-in syndrome, in which you are cognitively present, you are aware of your surroundings, but you're unable to move. You are absolutely paralyzed. And I think that that is just such a horrific fate. So definitely something that we want to be incredibly aware of as clinicians and very careful when we are correcting someone's sodium, especially if they've been hyponatremic for a very long time. So that's all I have for you on hyponatremia. I hope this video was helpful, and I'll see you next time.